So hello friends, welcome to my new video. So today in this video I am going to discuss with you all about a very important topic that we all should know, that is about proptosis. So from this video you will get to know what is proptosis, how the proptosis measurement is actually done, and what are the clinical steps that we will keep in mind while doing a workup of a proptosis patient. Okay, so let's start. So proptosis, that is the definition, that it is an abnormal protrusion of the eyeball from the orbit or socket where the corneal apex crosses the orbital margin, that is called as proptosis, and it is also called as exophthalmos. So actually proptosis and exophthalmos is near about similar, but exophthalmos is specifically used for thyroid disorders, where proptosis include several ocular pathology that leads to forward movement of the eyeball. Okay. So, as the eye has a forward movement in proptosis, so there is two ways to measure from the proptosis. Okay. First way to measure is keep the reference point on the orbital margin, like mostly the lateral orbital margin is the reference point, and by keeping this lateral orbital margin as the reference point, compare the movement of corneal apex from the orbital margin. So, this is how we can measure proptosis, or by comparing the two eyes corneal level, that is corneal apex level, and if one eye is more forward than the other and if the value is more than 2 millimeter, that is also called as proptosis. Okay. So, before going to this classification, I would like to say the causes of proptosis. So, proptosis can be unilateral or bilateral. The causes are similar. So, it can be due to infection like orbital cellulitis, or due to inflammation like thyroid disorders, or due to formation of a metastatic or tumor like cavernous hemangioma or lymphoproliferative, um, etc. And vascular lesions also include the lymphatic malfunction and structural disorders like orbital dermoid. So, this thing can lead to proptosis. So, let us come to this. Here the proptosis type, depending on the progression, it is acute, subacute, chronic. Okay. So, acute means when the progression of the proptosis is in between 1 week, there is acute. Subacute means when the progression of the proptosis is in between 1 to 4 weeks, that is subacute, and when the progression of proptosis is more than 4 weeks, that is called as chronic. Okay. And if I talk about the axial and non-axial, this is depending on the axis of the forward protrusion of the eyeball. So, in axial proptosis, eyeball move forward by an proper axis, that is axial, and in case of non-axial, eyeball will move forward and it can deviate in anywhere. So, depending on the deviation of the eyeball, you can assess at what location that lesion is there. Okay. So, this axial proptosis can be due to optic nerve tumor or cavernous hemangioma. Okay. And this non-axial proptosis can be due to orbital tumor or lacrimal gland lesion. So, this thing can lead to non-axial proptosis. Okay. So, I will show the pictures later slides. Now, how to measure a proptosis? So, the most common used instrument to measure the proptosis is Hertel exophthalmometer. So, how to use this Hertel exophthalmometer? Before that, we need to know what is the normal values of this Hertel exophthalmometer, then only we can understand that what is abnormal. So, the normal range in Hertel exophthalmometer is 4 to 17 millimeter, and if the value that we get in Hertel exophthalmometer is more than 20 millimeter, it signifies some abnormality is going on and it is a proptosis. And one eye is moved 2 millimeter more than the other, that is also proptosis, if the corneal apex distance is greater than 2 millimeter, and younger patient have this lesser value than the adult, but this value should be less than 20 millimeter. Okay. Now, this is how Hertel exophthalmometry is done, where this Hertel exophthalmometer having two groove here, this is the groove. Okay. So, you will place these two groove on the lateral orbital margin and you will measure the distance between these intra-orbital distance. Okay. And you will note down, because in each visit of the patient this interorbital distance will be same, do not change this distance. At first the value that we get in interorbital distance, that is the final value, and then you will check the progression of proptosis. So, in the mirror you will see the corneal apex and some scales. Okay. So, here you can see that this is the corneal apex and this is the scale like 10, 20, 30. So, you can see this line and this line. So, these two lines should be aligned properly and the corneal apex level should be less than this 20 value, then only it is normal. If the corneal apex crosses this 20, it is abnormal and which indicate proptosis. Okay. And this is the severity scale, where if you get the value in between 21 to 23 millimeter, it is mild proptosis. If the value is 24 to 27 millimeter, it is moderate proptosis, and if the value is more than 20 millimeter, it is severe proptosis. Okay. This is Lude's exophthalmometer. Okay. So, you can see this notch over here. So, you will place this notch on the lateral orbital margin and then measure the amount of proptosis. Okay. Another thing is that suppose the person do not have the lateral orbital margin due to any injury. Okay. So, how you will measure? So, at that time you will use this Nagel exophthalmometer, where it is resting on the superior and inferior orbital margin, and then the procedure is same as Hertel exophthalmometer. Okay. Now, pseudo proptosis. So, we talk about proptosis where forward movement of the eye is there, but what happened in the pseudo proptosis? In pseudo proptosis, the eyes seem to be have proptosis, but actually there is no proptosis. So, here that is why I wrote false impression of proptosis. So, it can be due to several reasons. First, due to presence of high myopia or lid retraction, facial asymmetry, or if there is presence of ptosis, there is ipsilateral lid retraction. These things can lead to appear of the two eyes that one eye is having protruded than the other. So, to rule out this pseudo proptosis, we have some test. So, you can instruct the patient to look upward, head tilting backward, and then measure the level of the corneal apex. Okay. So, here you can see the eye level. Here the patient right eye is normal, but left eye is protruded. Okay. So, this is a case of proptosis. So, this is how we can assess that yes, this eye is seem to be move forward than the other. So, it can be proptosis. Okay. So, it is not a validate that this process will work, but these steps will help you to move on to your clinical steps, okay, to understand whether the patient needs Hertel exophthalmometry or not. By just take a quick look by instructing the patient to look upward and see the level of those two eyes. Okay. And you can also do that, instruct the patient to see downward, and then also you can measure the level of the eye. Okay. So, in a normal patient, the two eye level should be equal. If one eye is move or move little forward than the other, it is proptosis. Even after in the exophthalmometry the value is less than 20, but you see that one eye is move 2 millimeter more than the other eye, that it is proptosis. Okay. Now, another thing is that to measure the axial or non-axial proptosis, you can use simply a millimeter ruler and place the millimeter ruler on the nose bridge and make sure that the millimeter ruler is crossing the canthus, and then you just measure the distance from this middle point to the corneal apex and at this eye also. Okay. And if you see that there is presence of proptosis, but the eye level is equal, that is axial proptosis. Okay. And if it is non-axial or eccentric, then after placing the millimeter ruler, you will see that this eye or this eye is little bit downward than the other. So, this is non-axial proptosis. Okay. This is how you will get to know whether it is non-axial or axial, and I already told you that depending on the movement, like eye is protruded forward and move backward. So, depending on that thing we can assess where is the lesion is there. Okay. So, symptoms, what the patient will tell you: redness of the eye, pain, difficulty to move the eye and dryness. Why? Because when the eye is normal, then eyelid can close properly, but as the eye is having proptosis, so this is why the eyelid is not able to close properly. So, it lead to some gap, and eyelid, upper eyelid cannot touch the lower eyelid. So, in between that gap it leads to dryness, and it also leads to exposure keratopathy. Okay. History taking. So, note down the chief complaint that the patient will tell you, and also duration of those symptoms. It is very important to take note of the duration. Okay. That how much time the patient is having this type of symptoms. Okay. And also note down the personal history of the patient, that whether the patient is having any addiction to smoking, alcohol like this. Okay. And do not forget to take the systemic history, because systemic problem can also lead to proptosis. Okay. So, never forget to take systemic history. Okay. Now, this is the flow chart of steps that you will follow, that is the workup of a proptosis patient. First of all, take unaided visual acuity, then objective refraction and find the best corrected visual acuity. Okay. But we will not prescribe any glasses, just measure the best corrected visual acuity. Uncorrected visual acuity and best corrected visual acuity is very important. Okay. After that, check the extraocular motility of the patient, that whether the patient can able to rotate his eyes in those 9 quadrant or not. If the patient is not able to rotate, just grade it like -4, -3, -2, 0 like this, in that you know very well. And after that, do the slit lamp examination, and also do not forget to check the RAPD to rule out any type of optic nerve lesions. Okay. And after doing the slit lamp examination, remember, do the slit lamp properly and note down each and everything that you saw in that patient. After that, IOP measurement and gonioscopy also be performed to that patient, and then do that color vision to the patient. Okay. And then do the exophthalmometry with the help of Hertel exophthalmometer. And then after doing this thing, dilate the pupil for fundus examination and do the fundus examination. Okay. So, this thing then optometrist can do, but the management section optometrist cannot do any type of management. So, this needs ophthalmologist. Okay. So, by doing this measurement and taking the history properly, we can refer the patient to the ophthalmologist. Okay. Now, you can see this is. So, after doing the clinical workup of a proptosis patient, do not forget to send the patient for CBC, ESR and thyroid profile checking, and also send the patient for CT scan and MRI. Okay, due to thyroid, and it is an axial proptosis. So here this is how you will measure the amount of proptosis. It is an axial proptosis, but look at this fullness of eyelid here in comparison to this. So it indicates there is something lesion is going on behind the eyeball. Okay, this seems to be a pseudo proptosis, and also measure the level, eye level properly. And yes, this, as I was telling, that by putting this scale, if you see that eyeball is little bit downward or little bit upward, put the scale vertically also. So you need two scale in case of non-axial proptosis. Okay, and then measure the displacement of the eyeball. Okay, this is non-axial proptosis. Okay. So that's all friends, thanks for watching, and please don't forget to like my video and subscribe to my channel, and please don't forget to hit the bell icon so that you will get notification whenever I upload a new video. And I hope this video helped you to learn something about proptosis. Okay, thank you so much.